So I know that was, I've heard the term, we've all heard the term, a picture's worth 1,000 words, right? That film was a mouthful, obviously. It's hard to come out and be the chipper MC after such a powerful and impactful film, but it was a real film. And so what we're here today to talk about is our response to that film. I'd like to ask a couple things. First of all, let me introduce myself. My name is Michael Jackson. Most people just call me MJ. And I'm with Amazon.
Why don't you bust some moves for us while you're out there and lighten this load up a little bit, MJ?
I left the glove at home, Bill. So that actually speaks to one of the things I was going to ask. So first, let me introduce myself. My name is Michael Jackson. Most folks just call me MJ. I'm with Amazon. Specifically, I'm with Amazon Web Services. Amazon Web Services is the cloud computing company within Amazon. We offer IT infrastructure so that organizations and companies and partners can do things in the cloud. We offer services like artificial intelligence and machine learning that enables companies and our customers to do things with data. So specifically at AWS, I lead our public health business. The way we define public health is healthcare organizations that are mission-driven versus profit-driven. So some of our largest customers are departments of health, actual states within the country, departments of health, public hospitals, the VA, and what have you. So before we get started, I'm going to ask the rest of our panelists to introduce themselves, but I ask just a couple things of the audience. Number one, please come in a little closer, if possible. If you guys up top could just come in a little closer, because that leads to my second request. We would like this session to be unlike any of the sessions earlier today. Nothing against those sessions, but this is a very serious topic, and what you have on the panel represents a cross-section of stakeholders who are tasked with addressing such a serious problem. And so I think in the audience we have an even broader cross-section of stakeholders, and so we would invite you to be a part of the conversation. We would like this to be a very informal discussion. We're going to do some introductions, but we don't want to hold the Q&A until the end of the conversation. We'd like to engage you so that we can have an open and honest dialogue. So
I'm impressed. Some of them are actually listening to you.
I love it. I love it. So back to my introduction. I was mentioning that with AWS, we offer our customers cloud computing and services that enable our customers to do things with data. And obviously, data can be a part of addressing this problem, but something that we all learned from the film is that this problem is not a problem of data or ones and zeros. It's a problem of people, right? At the core of this is not data, it's people. What we have found, though, is that data makes us smarter. And as a society, as a country, I think we're getting smarter when it comes to dealing with epidemics such as this. This isn't our first time at the rodeo, right? The first time, remember the 80s, early 90s, the crack epidemic? I think one of the ways we're getting smarter since then is we're not criminalizing the problem, right? It's really a problem of public health and not so much one solely of criminal justice. And some people may say, well, sure, because the demographic of the problem looks a little different, right? It's crossed into mainstream America. It's not one of racial or lower socioeconomic problems, but it really impacts all of us. But we're using that to be smarter. We're approaching it and we're attacking it in many, many different ways. And that's the beginning of the open and honest dialogue that I hope that we can have today. So with that, I'm going to pass it over to Dr. Bill Hazel. I'll ask you to introduce yourself, and we'll do that around the horn, and then we'll just have an open and honest discussion amongst ourselves.
Okay, thank you, MJ. I'm Bill Hazel, and I'm here under false pretenses. I am the former Secretary of Health and Human Resources for the Commonwealth of Virginia. I served 8 years and finished up Saturday a week ago, so I'm coming back to civilian life now, but yet I'm supposed to represent a government perspective. It's going to be awful. But so I'm going to show you some slides, but don't cringe. This isn't a PowerPoint presentation. This is just a little background information. This is a CDC map of estimated drug overdose deaths from 1999. This is 2004. Red is bad. That's not a political statement. This isn't a political map. This is just a heat map. This is 2009. This is 2014. So what Jenny has shown us is a very local, very personal piece of this, but this gives you just a flavor. This is the tip of the iceberg. These are just the deaths. These are just the deaths. And obviously there's a lot more out there that we have to deal with. So I wanted to just offer briefly, as secretary, I can tell you there are things that have taken over my life as over the last few years, and behavioral health, mental health, and opioids have been at the top of the list. We are losing too many of our people to opioids. And we took basically a 5-step approach in Virginia to solving it. I won't go into the details because these folks will have some of the pieces that they'll go into, but the first thing we looked at is harm reduction. Naloxone costs money, ties up resources. Infectious diseases, hepatitis, HIV, endocarditis has increased and is endemic, particularly where there's needle sharing. How do you address that? We have seen an increase in foster care. The number of kids coming into foster care because of opioids has doubled in the last 7 years in Virginia, even though the overall numbers have stayed level. There's crime. There's the time in jail. There's the lost productivity. And we aren't measuring those costs. Just to point out, nobody can tell us what that costs really. So, but we have to manage the harm because, as you saw there, not everybody's ready to go into treatment. And when they do get ready to go into treatment, it isn't always available. That's right. For a lot of reasons. So our second piece is then how do you get treatment set up? So we've expanded treatment through Medicaid. Like Utah, we did not expand Medicaid, so 90% of the people still can't get it, but you look at things like substance abuse courts, you look at screening and brief interventions and referrals to treatment to take opportune times to get people into treatment. So that's the second area. The third piece, and Rob will talk a little bit about this, we have to change the prescribing patterns. There are just too many drugs out there. One of the seminal moments for me, I'm a recovering orthopedic surgeon. I did my last surgery in 2010. I was one of the people that was writing these prescriptions and having people demand these prescriptions. And a high-intensity drug trafficking leader from Appalachia basically said, there are too many pills out there. We chase bad guys. We don't chase doctors and nurses. We got to fix this. So we've spent a lot of time on that. We can get into detail in the Q&A if you want. The fourth piece is interdiction. This isn't criminal justice or health. It is a disease. The disease is addiction. Don't get tied up on opioids. The drugs change. We've had crack. We've had meth. In Virginia, we still have cocaine and meth. And sometimes these are combinations that are killing. But so the drugs will change, but addiction will exist. And even when people get clean, they will be in recovery for long periods of time. So you have to get used to that. But we do have to continue to chase the bad guys. They are innovative. And Salt Lake has been victimized by some innovation in that over the last few years. If you haven't dreamed Dreamland, I would encourage you to do so. The fifth thing that we talk about in Virginia is culture change. And there are really 3 aspects of that we've looked at. Number one, how do you keep kids from getting started? And is there really an evidence-based program? Are there school-based programs? Are there 2-gen programs where you can get kids and parents together and talk about these things before they get to be a problem? The second issue that we have to come to grips with society is pain and pain management. There is ample evidence that narcotics aren't what we thought they were when we went through the 90s and made pain the 5th vital sign. What we do know is that there are other medications that work, but if someone is convinced that opioids the only thing that will work, doctor, it's the only thing that will work, you have to give it to me. You know what? They're going to be right. Placebo effect. So we have to come to that. And then the third piece is these people in recovery hopefully will have long lives. And they will relapse from time to time, but they need jobs, they need housing, they need food. Because without those things, they can't take care of themselves or their families, and they cycle back. So how we as communities decide to keep people in recovery is the other thing we've worked on in Virginia. And I will say that now that I'm not secretary, I'm really devoting a lot of time to how we engineer our systems so that they talk to each other better in order to get the data so that we can actually intervene more productively. So, thank you.
Thanks, Bill. My name is Alex Chan. I'm the CEO of the Clinton Health Matters Initiative. And what we do at the Clinton Foundation is build partnerships of purpose to solve big, intractable problems. And we've done this through the course of the better part of a decade. in global health, public health here domestically, climate change, environmental sustainability, but really in the past 5 years have focused on the opioid epidemic because it is truly a disease of despair. President Clinton is very fond of talking about this issue and framing it in that lens, in that this is a disease, this is a medical condition, and this is one in which is going to both require, but absolutely needs the participation, the collaboration, and the innovation from every sector and from every agency and department that is impacted or interacts with the outcomes of the epidemic. So at the foundation specifically, we do have a belief that everyone in this room and everyone in the US can do more and should do more. We see ourselves as a platform and a neutral convener, facilitator, and broker for that work to happen, and really where Bill has done so much great work nationally and with the states, our focus has been in communities and really looking at what are the solutions that are in the communities or that are being developed by community stakeholders, leaders, and key voices, and how do we at the Clinton Foundation and through our network of partners support them, highlight them, scale them, and get them into the hands of communities and individuals who need them most. And so our work is focused primarily right now in 7 communities across the US, but we are looking to hopefully scale and expand that work in partnership with quite a few people over the course of the coming years, because it is an urgent public health crisis. It is something that will require all of us to participate in and to collaborate in, and it is something that crosses at this point jurisdictional boundaries, socioeconomic boundaries and categories, and racial classifications, and it's only going to get worse unless we do something to make it better. So I'll keep it short so we can get to the conversation and the questions, but I'm happy to be a part of this conversation.
Thank you, Alex. And Rob Cohen.
Hi, I'm Rob Cohen, the president of Appriss Health. We provide technology solutions to states, prescribers, and pharmacists to really help address the problem, including Virginia. Yep. What that means is we provide prescription drug monitoring programs at its base. So we collect all controlled substance dispensations and then make that information available to physicians and pharmacists to, A, ensure they're not prescribing to patients that really shouldn't be prescribed to. Either because they have a history of controlled substances or they have some other indicators that they may be at risk. So things like history of overdose is starting to be reported. Toxicology data is a potential source, which Brad will talk about. Anything else that can help inform risk that would then inform appropriate prescribing or appropriate dispensing. And then these platforms are also starting to take a role in getting patients help, so getting patients to treatment. So as long as you've got a platform in front of physicians and pharmacists that's helping identify risk, how do we then move on to then helping the clinician help those patients get into treatment or get into other modalities of help? So that's basically what we do.
Thank you. And Brad Bostic from hc1.com.
Hi there. So as Rob mentioned, there's a big challenge around how do you understand the relationships and behaviors that are involved so that you can begin to drive positive change. And what HC1 really focuses on is specifically getting the richest view you can possibly get into what's going on with these different people. And one of the key questions is not only what drugs are being prescribed, but what drugs are actually in people's bodies. That's a big piece of the puzzle that's important. And we've ingested over 5 billion lab results and are exponentially continuing to organize this data in such a way that gives you live visibility into what the actual positivity rates are of different drugs across a population. So what we're trying to do is really collaborate with the broader sphere of people who can make an impact and determine how you can best become predictive. I will explain to people that you would never ignore the forecast if you knew there might be, it's hurricane season. You know, you would always be watching the forecast to say, like, what do we need to do to prepare for this? And so we see similar opportunities with data to try to get ahead of it and say, what's in the forecast based on using advanced technology. And we actually run on the Amazon cloud, and they can provide lots of capabilities for our team to use artificial intelligence and build these models that can get a lot smarter. So ideally, there is no perfect one-size-fits-all. This whole conversation's about the fact that it needs to be a multi-modality approach to ultimately drive positive change. But we think this piece of the equation is really important to understand what the drugs are that people are actually using across the population.
Thank you, Brad. And finally, someone who needs no introduction after that great film, Jenny McKenzie.
Hi, I'm glad to be back. So you heard I'm an independent documentary social worker. I have a documentary filmmaker who has a PhD in social work. So the first...
I think you were right the first time.
The first 12 years of my career, I was in the social work field, and then it really felt like a natural progression into social impact filmmaking with that social work background. And I think for me, my real goal is, I think, two-part, is to bring films about issues that are social justice, racial justice, public health pieces, and be able to bring an audience into a topic, into an issue in a very raw and intimate way. And as I'm sure you experienced, Dying in Vain is not an easy film to watch. It's not a happy bedtime story, but I feel as though opiate addiction and heroin addiction has been really closeted for a long time, as have many other of the topics that I've touched on. So to understand it and to bring leaders like this to really look at problem solving, I feel as though we need to go behind that closed door. And I think we need to really understand the suffering that is happening from the people who are not well. So my hope as a social impact filmmaker is to bring that film into communities. It's great if you get distribution on HBO, Hulu, Netflix, Amazon. Better throw that in there. Amazon. Amazon should have been at the top of the list. But what really is, I think, the most impactful is when you bring films into communities and create these kind of conversations, because then you are talking about technological changes, you're talking about public health changes, you're talking about different kinds of access. But to do that, I think you have to know the people who are suffering. And I think it's still so easy for us to hold them at arm's length. So that's really what I want to do, what I do. And then in my work, we put together educational curriculums that are companions to my films, and they're all available on my websites for free. So with Dying in Vain, we have a 39-page discussion guide that has resources for legislators, resources for physicians, teachers, all that kind of stuff. Because, as I said in the intro, one film really can't tell it all.
Thank you, Jenny. So this is where I think the more interesting part begins, right? This is where the dialogue begins. So if I could ask the AV folks, if you guys could go back to the first slide with all of our names and faces and titles so that the audience will know who they're addressing, that would be great on the big screen. And while you guys do that, I'll just frame it up this way. I think everything that each of these panelists said, the solutions that they offer, or the approach that they take, it falls within one of three categories or time continuums of addiction, if you will, right? There's prevention. There are solutions or approaches that we can take to prevent the addiction if you see signs before it really grabs hold. There's treatment of the addiction itself. And then there's ongoing support so that people don't fall into this cycle of on the wagon, off the wagon. So if I could start the discussion maybe with the first piece, prevention, unless there's a question that doesn't fall into any of those. There's a lady back there. Yes, ma'am.
What are the generations that are most affected, and why are they so vulnerable?
The question was, I know this is being recorded, so I'm just going to repeat it really quickly. She says, which generation is most affected, and why are they so vulnerable?
We are seeing it across the lifespan. I imagine that it varies from place to place. We see particular susceptibility in young people because the brain is still developing, and the theory is that they can do a lot more damage early on. But clearly, there are brain changes in response to taking opioids that I've heard from Professor Johns Hopkins that begin to occur within 48 hours. So it happens very quickly. Another area, and you don't think about it in seniors, but you have people who have lots of aches and pains and maybe are getting medical treatment for that. They're mixing medications. You're seeing populations with benzodiazepines where there's a co-prescribing going on. So it really can cross the lifespan.
But recently, I mean, in terms of mortality, the biggest mortality jump has been in, I think it's something like 23 to 30-year-old men. And that's what we've seen, I think, recently. They stopped the credit roll, which was great for time in the film, but our end song is actually a song by Macklemore, who is in recovery himself. And we have 3 slides in the end credits. And just to throw a little additional information out there, the United States has 5% of the world population, and we consume 80% of the world's opioids. It costs the United States roughly $50 billion a year in terms of people being out of the workforce, public health issues, all of the other costs, and really the criminal justice system. And then 85% of heroin addicts begin with prescription pain pills.
That's, I think, the big thing is it starts, for the most part, with prescriptions, and that's what I think we tend to not always realize. I've had people who should know ask me that in law enforcement meetings. Do they really start with that and use it properly and then get addicted, or are they just bad people? And they really start with medication. And I think that's what the profession's had to learn.
Yes, ma'am.
I'm really interested in the map that you had here earlier, and the fact that they were, very concentrated on the west, Malaysia, some up in the east, and then there was a pocket in the mid. I'm not sure what state. Is there some correlation of where these spots are? That's one question. The other question, I know very little about the subject. How much of these opiates are produced internally as opposed to coming through the border, which is another something that I don't understand. And how do you make the transition from opiates to heroin? What is it that's the trigger for that?
Okay.
All right, so
let me
just want to repeat the question.
Okay, so the question is where do the drugs come from? Are they made in the U.S. and imported, and what are the percentages of each? I think another question was, is there something unique about these areas that are in red that makes them susceptible, and what was the rest of it? Oh, how do you transition? What makes you transition?
From prescription drugs to heroin.
Okay.
Yeah.
You go ahead with the pictures if you...
Well, I wasn't going to speak to the pictures. I was actually going to speak to some of the work that we're doing in communities, or to your second question about where are the drugs coming from, or where are the opioids coming from. The problem is it's complicated because there are legal opioids. That's a very easy answer out of this, is it's complicated. But there are a variety of opioids or substances that are classified as opioids. There are legally prescribed opioids, which are manufactured here in the U.S. and abroad, that are prescribed by clinicians and prescribers, and that are used by everyday people just like you and me. And that, I don't necessarily know where exactly.
That's the 85% that is cited as the starting point for much addiction, whether it's kids sharing pills at pill parties or people like me providing them to patients and they begin to get addicted. And that's the 85% piece.
Right. And then there's a classification of opioids now, and there's synthetic opioids that are coming into communities, especially the ones that we work with, and they come by, there are a variety of names, but the most common one that is being seen on the streets goes by the name of carfentanil. A lot of that is fentanyl and carfentanil. Fentanyl, sorry. And a lot of that is produced overseas, but it's not produced necessarily by the countries or the places of origin that you would assume. And so it's a mix, and it is highly variable depending on which substance or which type of opioid we're referring to.
The opioids that we're getting to Salt Lake, if I understand the history correctly, are coming out of northwest Mexico through a network distribution there. It's sort of a Domino's Pizza thing where the folks come up and you call a number and they deliver to you. What happens to these folks is that once you're addicted, there's a certain cost of keeping up with the prescriptions. And you have to pay for the pills, basically, or get them. And the challenge and sort of the nuance in policy, and frankly, legislation is not good for nuance at all. And regulation is not real good for nuance, but it requires nuance in this because the harder we make it for people to get legal medications, and they're still addicted. The absence of the substance doesn't take away the addiction.
That's exactly
they have
right.
the craving and they go to the street. There is no FDA out there. We've gone from the pills, the OxyContin, heroin. Heroin gets laced with fentanyl. The carfentanil is actually used for veterinary surgery with large animals like elephants. They are so powerful that even law enforcement, emergency responders, lab personnel come into contact with it can overdose from them. I mean, and so I think why you're seeing deaths of in that spur in that male population is the illegal piece. And why this is, as an addiction problem, is different than, say, alcohol. If I'm an alcoholic and I go off the wagon, I don't run the risk of dying immediately with my first hit of alcohol. When you have been out of the use of the drug for a period of time, your tolerance goes down, the doses you were using before you can't use, and then that becomes a problem. And I have a friend who was chief of state police in New Jersey, said they just arrested a dealer, and 1 of 15 bags is designated hot, lethal, and that's a selling point. 1 of 15 bags this guy was putting out would kill people, and everyone knew it, and they wanted it. It's what it does to your brain.
So to that question, I think, Brad, you may be able to add a little something as far as not just the transition from prescription drugs to what we call street drugs, but how does your solution help to identify not just abusing the availability of prescriptions, but understanding what is being taken in the first place?
Yeah, I'll answer that maybe a little differently than what you specifically asked, but when you talk about who's doing the drugs...
Are you a politician too?
Okay, come on, Bill. All right. So when you talk about who's been doing the drugs, the trends sometimes are very counterintuitive. Like the state of Indiana actually subscribes to this live insight that we provide into drug positivity, and one of the big things lately that's really shocking is that by far the largest increase in fentanyl positives are coming from upper middle class people. That, you know, this is not a problem that's only for people who are living on the street. You know, this is actually a problem that's, it's almost like when you see the old story about the frog being boiled, and you know, if the frog jumps into the boiling water, it jumps right back out. But this isn't like that. This is where the water, you know, is really comfortable, and then it just kind of continues to get hotter and hotter. And by the time you get to this boiling point, you know, it's too late. So there is a lot that can be done, I think, to intervene sooner by being more predictive with what we're seeing come down the pipe.
Can I add one thing? The distribution channels, you can go on the dark web now and order fentanyl from China, and it will be delivered by the Postal Service to your house. That happens, and so that's an issue, and it's not just from China. The other thing that is really scary is, you know, we all have heard about the methamphetamine problems and the meth labs and the explosions and the fires. Well, did you know that you can get the ingredients for fentanyl and you can make it at home without the explosions? Now, think about what happens to the addiction epidemic when suddenly people can make this stuff at home. So these are things that that we have to look at too, and why it's not, you know, the local response around culture change and intervention and welcoming people back is so important, but we still need the national policy and the border issues and the law enforcement chasing the bad guys, because they are creative and they're evil.
Yes, ma'am.
Now, that sounds oxymoronic. You're going to put me back in government, unshackled, with plenty of money and no politics.
How would you address the problem?
Well, a couple things. The first thing I would do is do the obvious things. We need more treatment, and we don't even knowing if we had the money to pay for it. We in Virginia, I think Danny Vula here is our health director in Richmond, can tell you, we've created a model drug treatment program through our Medicaid program. So you need to have the treatment available and the ways to pay for it. So that clearly has to happen. And we then have to go where we know harm is and mitigate harm. I mean, those are immediate things that you have to do. Stop the bleeding if we can. Then we've got to really look at, and it's going to boil down to the culture. We've got to change our minds as a country about ingesting this stuff. At the long and short of it is this cannot be all by prosecution and law and things like that. Somewhere, the people are going to have to say, you know, we're just not going to tolerate this. And, you know, the people who have to be more aggressive in the prevention. The pills are bad. Clearly, you know, we've done a lot in reducing the pill supply in Virginia. We've implemented the CDC guidelines for acute and chronic pain as part of our Board of Medicine, Board of Pharmacy, Board of Nursing, and guess what? Board of Veterinary Medicine. Because people go to vets and get big bottles, jars of pills for their dogs. I mean, so it's in so many things that we have to get to that, and then we have to give people in recovery hope.
To that point, I would argue sometimes we tend to simplify things and say, we're going to go after the bad guys, or just make it an issue of black and white. And I think that is a very valid statement and point, as long as we understand that the bad guys are the suppliers of the illegal drugs,
yes,
not the consumers of those drugs. I think we learned from the film that these are individuals, they could be heads of households who have a very valid fall, and they get prescribed a pain medication, and then the script runs out and they find themselves addicted, so then they turn to illicit means of trying to achieve that same feeling, right? And so I think it's important for us to understand who the bad guys are, and to, as society, overcome that stigma.
Well, I think to build on and sorry to jump in is that if I as an orthopedist have been prescribing you medicine and you get addicted, I don't look at that as a moral failing on your part in any way, or even a mistake. You were following directions and doing what you were told, and now your brain has been hijacked, and it so shows in the studies, you can see it. You don't really have that control if you're really addicted. Now, there are people who make bad decisions. The kids who use pills and things like that, it is easy for someone in the political world to say, oh, that's bad judgment. But once you're addicted, the judgment's got nothing to do with this anymore. And why the mistakes these people are making are so deadly is because the substances are so bad. Which one of us did not do something we wish we hadn't done when we were younger, but we didn't get addicted and didn't kill us?
And Bill, it's important to note on that point, when prescription drug monitoring programs began, they started living within law enforcement agencies within the state. The belief was, we'll go catch the doctor shoppers and the pill mills, the bad actors, and we'll solve this problem. And it was relatively quickly discovered that that wasn't the problem. And now the vast majority of states, those programs will live within the Board of Pharmacy, the Department of Health, and they've shifted away because there's been that realization.
And to that point, your company, Apris, not only allows for transparency into the prescribing of these drugs, but you allow for collaboration between states, right? So could you talk a little bit about that?
Sure. So it was also the case years ago that states did not share data among their programs, which was obviously a problem as people cross borders to get their prescriptions filled. But now the vast majority of states do share data across state lines, so physicians and pharmacists can have a holistic view of the dispensation history and other data that when patients are presenting.
Why that's important is there are parts of Virginia where within an hour you can be in 4 or 5 different states. And that shopping occurs. But since she gave me authority to do anything I want to do as government, one thing I would do is we do have one federal policy that limits the ability and the effectiveness of the prescription drug monitoring programs, and that's something called CFR 42 Part 2, which has to do with behavioral health information. And the methadone clinics, the drug treatment clinics that actually dispense on site are exempt by federal law from reporting to the PMP, which means that you can still be drug shopping and we can't tell. It creates a blind spot. Now, there are a lot of other problems with that too, but I would ask everybody here to think about how we can fix that problem, because we don't need the blind spots.
All right, and there's a question over here. What I'm going to do is ask that we do a more of like a round robin, because I'm keeping an eye on the timer that's clicking down too. So we'll try to get as many questions in as possible. Yes, sir.
And
summarize.
it's really detox. It's detox that they're not covering, which is interesting because I think they define it as not medically necessary because they really say,
Sorry, could you just repeat the question?
no, you go ahead, MJ.
I'll paraphrase. He basically asked about the role of payers, health insurance companies, and I'm sorry to interrupt. I just
Not
wanted
at
to
all.
repeat the question for the sake of the recording.
Yeah, and I think you were talking about treatment, and it's a giant problem. I mean, we still don't provide long-term access for a chronic recurring medical condition, which is exactly, we are in the middle of a paradigm shift and moving so that we are not seeing addiction for what it used to be identified as, which is a moral failure and a problem where you just aren't pulling yourself up by your bootstraps. But the challenge is with opiates now, which is what is the biggest issue in detox centers, many insurance still are not covering opioid detox because even though you feel like you're going to die, there is not medical necessity. You feel horrible and you often need that medication, but they do cover longer term treatment. It's just usually 6 weeks. And then if you relapse or if you need continued care, that coverage is not there.
I'm just going to add on to that because I think it's a two-pronged issue. It's what do they cover and where are those covered treatment centers accessible to a large majority of the population. So you mentioned that detox is, and not by and large, but there are quite a few insurers who do not cover detox treatment. But there's also medically assisted treatment, which provides people who suffer from addiction and who are in a treatment center prescribed amounts of opioids to lessen the impact, the immediacy. So it's not a cold turkey approach to stopping addiction. It's a measured clinical approach to reducing dependency on an opioid. And by and large, those services in those treatment centers are also not covered. And where they are covered, they're very few and far between. So you may live in an urban center where you at least are within, hopefully, 30 minutes by private transport, or if you have to, public transport to receive that type of treatment. But in areas where there isn't a treatment center, even if you're covered, how many people are going to drive 2 hours to get the necessary treatment on a daily basis that they need, day in and day out, over a prolonged recovery period? And that's one of the real critical challenges. It's the coverage piece, but then it's also the accessibility piece.
If I can, so Medicaid program in Virginia did a couple things. First of all, 2 years ago, we implemented a pre-authorization requirement around prescribing opioids. That was one of the questions you asked. We saw within the first 3 months about a 50% drop in the number of opioids that were prescribed and about equivalent amount of payment decrease for opioids for Medicaid, but only about an 11% decrease in the prescriptions written. And we interpreted that to be better prescribing patterns based on an insurance company plan. Not all the plans have picked up on that, but we've encouraged that. We also have looked, one of the issues with medically assisted treatment is the major drugs are methadone, which are done through federally licensed clinics, buprenorphine, which is done through doctors' practices, and then there's something called Subutex, which is a monoproduct in part of Virginia, in our Appalachia part of Virginia. That is actually the drug of abuse now. And so you don't want to think about this as one problem every place, because our judges, when we want to have drug courts, they say, why would we give them what they're breaking and entering to get? And so what we did is we put some rules in around prescribing the Subutex monoproduct, and we saw a 35% decrease in that and a 35% increase in the less abusable Suboxone, so it does work. When we put in our addiction and treatment services waiver, addiction recovery and treatment services arts waiver, I think we've seen, and I don't have the numbers in my head, but like a 400% increase in practices available for treatment that have gone through the process for outpatient-based addiction treatment. It's been remarkable. The problem we're having now is that it's much easier for people who are addicted to go pay a methadone clinic or a pill mill $100 and get your pills than it is to invest in medically assisted treatment, because the key word is assist. And incorporating peers, as you saw, is really important in this process, both for them and the patients. The issue with plans in the commercial side, they haven't followed suit. Think about it. Do you want to be the first insurance company in your state to say, we're going to cover addiction with a state-of-the-art program? Think about the adverse selection you'll have. I mean, we've seen this with HIV and other things. So that's where you have to think about a level playing field as a mandated benefit package if we're going to have it.
Thank you, Bill. Yes, ma'am.
Yeah.
That's a great point. So let me rephrase the question really quickly. So the question was, how do we take an active role in reaching out to the children and those impacted most, the young people? I'll take a quick stab at it, and then I'll pass it on to others on the panel. So we started by saying that the first part of the time continuum is prevention. And most of us are old enough to remember in the 80s, remember Nancy Reagan, just say no, right? Or this is your brain on drugs. So it's not enough today. I think the kids are much smarter. They've got so much more access to technology and to each other. You used to have to call your friend's house and speak to their parent in order to get to the friend, right? And they'd have to, now you can reach out directly. So I think one means of leveraging technology to get messaging that resonates is to leverage the channels of communication that they use most often, right? Whether it's social media or what have you, right? So the same way that we can personalize a splash screen when you come to an e-commerce website, because what you see is not the same as what you see based on your purchase history, we can personalize messaging that we know will resonate through various digital
Does Amazon
channels
do
as
that?
well. They may, I don't know.
You know, okay, different area, huh? Yeah. Okay, just checking.
Yeah, I don't handle the retail.
You don't handle that? Okay.
But no, in all seriousness, the same technologies for personalization and resonant messages that are going to stick can be employed for purposes that have a lot more at stake.
So a couple things that you can do. I don't know the LA school system, but there's probably someone in the school, and there's probably someone here who can answer her question better than I can, but go to the school. There will be a school counselor. In Virginia, everybody bought into school resource officers, which is why we have one of the largest populations of kids going from school to prison. You know, you put police in to do things, and they use their tools. So, but there will be people in the school who should have some responsibility to track it down and determine, you know, what they can on a soft way, the truth, and to intervene. If you really have a kid that's selling pills, you've got a law enforcement issue too, and that's another way to approach it. If you can't get, you know, if you can't stepwise get to it, but you also, you probably, if this is a football stud, he's seeing somebody like me. I worked with the Redskins for 7 years and DC United soccer team for 10 years, so I was a sports medicine guy. So he was selling pills probably that I was writing prescriptions for. I wouldn't know that necessarily. So somehow we have to tie those feedback loops together.
I don't have a specific answer to your question or that specific situation, but what I do want to say is, and I think you saw in the video the importance of naloxone. And the Clinton Foundation has partnered with Adapt Pharma, which is a manufacturer of naloxone, to make naloxone available in every high school in the United States. So in that conversation with the school counselor or with the school administration, I would also ask about the accessibility of naloxone on campus, because if you have someone selling, then you must have somebody using on campus. And not that in any way we are seeking to normalize addiction and dependency, but recognize that it does exist And should an overdose occur on a campus, either high school or a college campus, we don't want people to die from that, and they shouldn't die from that needlessly. And so I would also encourage you to ask about the availability of naloxone, and if there isn't, I'm more than happy to connect you onward so that the high school can receive the kits and naloxone.
And I would have a specific conversation with your sweet boy, and I would just say how happy you are that he shared that with you, and that it concerns you so much, and that you were at a conference and you saw a powerful, scary documentary about opiate and heroin addiction, and you'd like to watch it with him. Our film is on Hulu, Amazon, iTunes, and I would watch it with him. Then I would have the next level of discussion, and then I would say, given this football player's situation, I would like to take this to the school's administration and see if they could show this at a school screening in the evening, so that high schoolers can come with their families and have a two-generational conversation, because this is what this kind of a film is about. You could get naloxone there, you can have someone who is local do a naloxone demonstration, and you can, again, create conversations in your community that really, I think, is that first piece in prevention.
Just one thing. Athletic trainers are your friend in this, most likely. Generally, your coaches should be too. If you've got a football team-related problem, and at least in my world, I could trust the people that I worked with. That may be situational. You have to pick who you trust.
So I'm getting the signal from backstage. So in the interest of time, we'll take one more question. I saw this gentleman's hand up. And then what I'll ask is for each of the panelists to offer words that they would like for you to leave with, final parting thoughts. If you don't remember anything from today's session, what it is that they would like for you guys to take away. And afterwards, because I know that we are tight on time here on the stage, but personally I'll be around. I think many of the panelists will be as well if you'd like to continue the conversation, because I think this is one that certainly needs to be had. So, yes, sir.
That's a real good question. And some of it, I think when you look at what drives addiction, there are genetic factors, but I think what we've learned in healthcare and others is that they're what we would call the social determinants, things that are happening in society that impact people's health. And some would look at this and say, boy, that's the Trump electoral map. And I've had that happen before. Not to make a political statement about Trump or something, but one of the things, the theories is that's a part of the country where things aren't working out for people like we think it should be, that big hotspot of Appalachia. We know in New Mexico, in one of the Indian tribes down there, it's a rite of passage that you get your first heroin injection when you're 13. Some of that in this is due to the proximity to a drug distribution network that came up from Mexico through New Mexico, Arizona, Nevada, in Utah, and that's the one that swung through to the Middle East. So it's multifactorial, but I would think about this as a disease of despair.
Thank you. So on that note, why don't we start with Jenny? You look like you have something to say.
Sure. I just think my closing remarks would be talk about addiction. Addiction is a disease, and the more we talk about it and bring it out of the closet, the more we're going to be able to do with it, because no one is immune.
Yeah, I just say it starts with all of us and every person in every community making a decision every single day. And I do think that transparency and open dialogue is really critical to this, because it's easy to pretend like that's not my kid or that's not my kid's, school or whatever. And we're seeing this thing permeate, every facet of our society. So to the extent that we can get ahead of that and become proactive and make a cultural shift around this, I think that's the best thing that we can take away.
To build on something Bill started to say, on the healthcare side, this really gets back to the bifurcation of behavioral health and physical health. You may have heard about mental health parity over the last few years. It includes substance abuse as well, and that explains the data gaps, 42 CFR Part 2, what's covered and what's not, and we need to continue to break down those walls on the healthcare side.
My hope, aside from what these fine folks have said and will say, is when you go back into your tables and your conference rooms, look around the table and see who isn't in the room and who needs to be in the room. If you're a hospital system, are you engaging with the public health department? Are you engaging with the juvenile justice, criminal justice, and public safety agencies on this issue? Are there representatives from communities that are most impacted by this epidemic, both in its current form, but in its previous iterations? Do you have people of color at the table that can advocate for the needs within their community and their population? And if not, make the space and give them the agency and the authority to participate.
This is addiction. Opioids are the current manifestation. This is a behavioral health issue. It's interesting, the frog hasn't jumped out of the pot at all on behavioral health around this country, and yet it is an underlying factor that we need to think about this. The second thing I'm going to tell you, just a brief anecdote. We had one town that was getting the people together and was going to create a diversion program so that people with addiction would get treatment instead of jail. You know who sunk it? The sheriff. Because, and you got to understand these things, if we diverted everybody with substance abuse and mental health issues from jail, he wouldn't have any inmates and he wouldn't have any budget to pay for his deputies. It's complicated.
Wow. So to that point, I think that really speaks home to what I would like us all to think about when we leave here, and that is there are so many interdependent factors in all of this. Young people who are battling addiction either become older people who are battling addiction. They find help and they battle it in a chronic way, not unlike any other disease. You know, if you're battling cancer or any other illness, it's a chronic disease that needs ongoing support, or they die, unfortunately. So I would like you all to remember that, and these aren't my words, these are the words of Elijah Cummings, who's a congressman out of Maryland, but he said how did he put it? The cost of doing nothing is not nothing. That's how he said it. The cost of doing nothing is not nothing. And so those interdependent factors that start to play in, whether it's, you can call it the social determinants of health or what have you, but it's behavioral health, which could turn into substance abuse, unemployment, homelessness, all of the things that plague our communities, they are not in silos. They all lead to each other, they depend on each other. And so I think if we could just remember that the cost of doing nothing is not nothing, whether it's speaking to your child's coach or talking to people in your community or having an honest conversation with your own family members.
Yeah. Could I offer one thing? This sounds it's pretty heavy and we're all sitting here overwhelmed. In World War II, the Allies were getting beaten all over Northern Africa, and there was a battle at El Alamein, which turned the course of the war in Northern Africa. And Winston Churchill said after that, this isn't the end. It's not even the beginning of the end, but it's the end of the beginning. Because we have, as a country, begun to recognize that this has become a mental health issue, that we do have to deal with this across our cylinders of excellence. We've made that. So we're getting near the beginning of the end now. And this is going to be a long-term project, but we can do this. And we are doing this. And I just want to give everybody a little up. As hard as it was to watch that, we're on our way. But it's going to take all of us going back and making it happen.
So with that, I'd like to thank you all for your time. This has been great.